Okay, hold on, it's counting down again. Is it working now? I apologize, everybody. We're having some technical difficulties with the broadcasting system. So bear with us as we fix this. It says we're broadcasting, but it's showing that it's going live and that it's working. Is it? This is live streaming, yes. Okay. Again, everybody, I apologize and thank you for bearing with us as we work through the internet issues today. I'm going to turn it back over to Dr. McAllister.
So what I was speaking about is what's called radiosurgery. This concept that we try to deliver radiation treatments in a three-dimensional model as opposed to a traditional two-dimensional model, which is what had historically been utilized. In 2005, Riverside purchased the Gamma Knife unit. The original unit was called the 4C. And since that time, we've had a unit called the Perfection unit. And now we've recently, right about the time this pandemic with coronavirus began, we upgraded to something called the Gamma Knife Icon unit. We also have another device in our radiosurgery center, which we collaborate with folks from the University of Virginia as well as from Chesapeake Regional Medical Center with. We have something called the Variant Edge. My predominant use or my predominant role in the radiosurgery is with the Gamma Knife, because the Gamma Knife is designed exclusively to treat lesions of the brain, which is a neurosurgeon is where my surgical interests lie and where my expertise lies. Basically, what the Gamma Knife allows us to do is to treat things anywhere in the brain, assuming they can be defined radiographically, either with an MRI scan, which is our typical modality of imaging, a CT scan, or sometimes an angiogram, which is a test looking at the blood vessels of the brain. The way the Gamma Knife Icon unit works, the way all the Gamma Knives work, is that they are a bunch of individual sources of radioactive cobalt that are stored in lead casings that we can automatically open. The Gamma Knife Icon unit has 192 sources of cobalt. They're in a dome that is, when it's closed, there's no radiation being emitted. But if we open it up, they sit in what are called collimators. The collimators can be open or shut, or they can be open to either a 4mm diameter, 8mm diameter, or 14mm diameter. And using those 192 sources that are wrapped around the patient's head and adjusting the size of those collimators, we can create little three-dimensional molds of radiation down to about 3mm round that can conform to targets within the brain. And that allows us to treat things. The most common thing we treat are tumors. The most common tumors we treat are metastatic tumors. Tumors of the lung, breast, liver, skin, melanoma. They do occasionally metastasize or spread to patients' brains. And unfortunately, that's not an uncommon thing, particularly for lung and breast cancers, which are the two most common cancers that we see here in the peninsula. And if they spread to the brain, you've got basically three options for dealing with. We've got four options now, but three traditional options. One is to operate on them, which if it's a single lesion and it's large enough and the patient's having symptoms, sometimes we'll do. Another option is to treat it with conventional radiation, which is referred to commonly as whole brain radiation. That's usually given over 10 separate treatments. And then the last option, the more modern option, the more precise option, the option that we now currently favor is doing what's called radiosurgery. And essentially what we do is we get an MRI scan and you can see these tumors because they're not brain tissue. They image differently on an MRI scan than does normal brain tissue. They have a characteristic appearance that if you know the patient has, for instance, a previously diagnosed lung cancer, kidney cancer, breast cancer, whatever the case might be, cancers that spread to the brain have a fairly classic appearance on an MRI scan, so you don't have to biopsy them. You can be rather certain that that's what it is. And cancers that spread from the brain tend to have a well-defined margin, a well-defined volume, a well-defined shape. And as long as you can draw it and define it on an MRI scan, we can treat it with a Gamma knife. Previously at Riverside, we had a Gamma knife 4C and Gamma knife Perfection, and we were somewhat limited with that because there were considerations that related to the volume of the tumor. And the issue was that any tumor that was about 3 centimeters or greater across, the way the physics of the radiation delivered would be such that the amount of radiation that would go to surrounding tissues, which the Gamma knife is very good at limiting, would actually exceed what we were willing to tolerate, what the patient's brain could tolerate. So those tumors either had to be treated with whole brain radiation or surgery. But now with this new device called the Icon, we can treat these tumors. We can treat multiple tumors. In fact, I had a patient last week that I had, I think, 19 separate tumors that we treated. We actually were able to break it up into 2 sessions. And the difference is that previously with the Gamma knife, one of the things you've got to be able to do to treat something stereotactic with radiation is hold what you're treating still. Because as these radiation beams are going on, if you wanted to be precise, the tumor and the patient can't be moving in the middle of the treatment. So traditionally, the way this was achieved with a Gamma knife was that we would bring the patient in the morning of the treatment, and with our anesthetist giving the patient a little bit of sedation, we would actually put a frame that would screw directly through the scalp and into the skull that was attached to a titanium box. And that would hold the patient still, both for an MRI scan, perhaps for a CAT scan, and for the treatment. Their head would be bolted into the frame that their body laid on. And that would, and essentially the way these 4 pins went in your skull, it was impossible to move your head more than a fraction of a millimeter. And so for the previous Gamma knives we had, that meant that generally we were only going to treat the patient one time, because putting this frame on over and over again, even if it's separated by a week, was in general sort of an unpleasant experience. Although most patients don't complain about it, we didn't want to do it more than once. The beauty of the Icon is that we can now treat patients in what's called a mask, which is a plastic molded a device that goes over the patient face. It's mesh, so you can breathe through it, you can see through it, but it's rather tight on your face, and it's specifically form-fitted and made in our radiosurgery center. And using special sensors that are then attached to the patient's scalp, as well as to just adjacent to where the radiation sources are, we can follow the patient's head. And so if we've got someone, for instance, we had a lady we treated on Monday who had a history of lung cancer. She had symptoms, actually weren't directly referable, but when her oncologist, medical oncologist, ordered an MRI scanner, she had a rather large tumor, actually 2, but one particularly large, in the back of the brain called the cerebellum. And generally we don't operate on people who are asymptomatic or who have more than one tumor, although occasionally we will. But her situation was such that we thought that radiation would be ideal. Now, we could have treated her with whole brain radiation, but the problem was from everything in her brain, from her ear up, was stone cold normal. And if we had done radiation, whole brain radiation, we would have been radiating parts of her brain that didn't have cancer and didn't need radiation. And even if you break radiation treatments up into 10 small fractions, which can be lethal to a tumor, and it looks like it isn't lethal to the brain, ultimately it's sublethal to the brain. We know this because you see these people 3 weeks after their treatment and all their hair's fallen out. So you know that it's destroyed hair follicles, and there are cells in your brain that will wither away over time. And one of the nice things about dealing with cancer in 2020 is that diagnoses, when I was in residency back in the 90s, if someone presented to the hospital with a metastatic brain cancer and we operated on it, or we radiated it, the average survival was measured in months. You would put people through a brain operation, a radiation treatment, and then if you were lucky, on average, they'd live 9 to 10 months. And that was considered a good outcome. And it wasn't because our surgeries didn't work. It was because generally if someone had spread cancer to their brain, it meant the cancer was spreading elsewhere and they were out of options for chemotherapy. But in 2020, the state of medical oncology has advanced so much with all of the various immunologic methods that they use to treat cancer now that are directed at specific antibodies on these tumors, that even someone who shows up with widely metastatic brain cancer, if they've not run through the whole gamut of chemotherapeutic and immunologic modalities of treatment, they can have a survival that can be measured in years, not months. So we are far more aggressive now in both operating and radiating these patients with metastatic cancer. And one of the upsides to, you know, giving people radiation is keeping the radiation from doing long-term damage. So if you take someone who's got multiple metastases in their brain, multiple metastatic brain tumors, and you give them whole brain radiation, but then they're going to live 5-10 years from that event, there's a fairly high likelihood that they've received whole brain radiation that there's going to be some neurologic consequences of the whole brain radiation. The most common one is memory loss, which everybody's met someone or known someone who's had Alzheimer's and had bad bouts of dementia, and no one wants to ever inflict that upon someone, particularly as a result of treating a medical condition. You don't want to trade one condition for another. So one of the beautiful things about radiosurgery and treating these tumors with the Gamma knife is that while we haven't eliminated the risk of dementia, it is far less. There's no question that these patients that we treat with Gamma knife, because the radiation treatment is not going to the whole brain, it's only going to the tumor, that we've been able to significantly impact the onset of radiation-induced dementia. And so that's been very, very gratifying for everyone. It makes taking care of these people easier. It obviously makes their quality of life higher, and it makes their loved ones have more time with the person that they know and love. So, and with the Icon, the beauty of that is that we can take larger tumors that we used to feel compelled to treat in one fell swoop with one dose of fractionated radiation in one day, and now we can treat them. And we, like for instance, the lady I mentioned earlier, we're going to give her 3 treatments of radiation. So it's kind of combining the old whole brain radiation, which was 10 treatments, with the benefits of stereotactic radiation and using the best of both worlds. It's a radiation treatment that's conforming to the actual volume of the tumor, not going outside and affecting normal brain tissue. But because of these larger tumors, there's a little bit more spread of the radiation, breaking it up. And usually these treatments happen every 5th or every 6th day and are very easy to tolerate. The second and third treatment for the lady that we treated on Monday will be done in the mask, not in the frame. And she should have a good response. I was just in the office seeing patients. We got a result on a patient who had presented to the hospital with metastatic melanoma, which used to be quite frankly, a death sentence. People with melanoma did not do well. Even if you operated on them, the tumors recurred. Unfortunately, melanoma, much like renal cell cancers, is what's called radio-resistant, meaning that small doses of radiation done over small fractions don't usually work that well. But for whatever reason, Gamma knife radiosurgery works very well with melanoma. And this lady, I think I've operated on her twice for tumors that have bled in her brain. We've treated her with Gamma knife 3 or 4 times. She's well over 1.5 to 2 years out from all of these treatments. She had an MRI scan, I think 2 weeks ago. And other than seeing the scars and the holes in her skull where I did her surgery, you couldn't tell that she'd had cancer in any way, shape, or form in her brain. And I think she's had a grand total of 6 tumors, and they've all been rather large. And there's no current evidence of that. She's still getting chemotherapy for her primary melanoma, but she's doing remarkably well, considering historically where she would have been with a similar diagnosis, even say 10, 15 years ago. And we've got a lot of patients like that. We have patients with renal cell cancers that have spread to the brain. I have one gentleman that I think I've treated with Gamma knife radiosurgery for his renal cell cancer spreading to his brain 8 times. And other than a little bit of a limp on his left leg, he really is remarkably asymptomatic and still living a full and normal life. And he has probably had 23 separate tumors treated with radiation in his brain. And to date, as of about 3 weeks ago, they still all remain at bay. His last radiosurgical treatment was sometime in the spring, and he's had 2 follow-up MRI scans. They've all looked good. So we've really been able to expand our ability to benefit patients with metastatic brain cancer. That's not the only thing we treat at the Gamma Knife Center. With the Gamma Knife, we treat benign tumors. I just saw a lady in the office not 45 minutes ago who had a tumor in a part of the brain called the cavernous sinus that was slowly growing. And if we didn't treat her, she was likely going to end up with double vision and or go blind. We were able to treat her with Gamma Knife, which meningiomas usually respond very well. As long as you keep them from growing any bigger, they usually do well. So that was the goal of her therapy. I just saw her. She's had no side effects from her treatment. She'll get a follow-up MRI scan in 6 months, and we'll continue to document that she's responding. We treat meningiomas. We treat tumors called schwannomas. There's a particular tumor that grows in and around the nerves that control balance called vestibular schwannomas, for which surgery can oftentimes be risky and risk the ability to move your face and lose your hearing. And when we treat these tumors with Gamma Knife, we seem to have just as good a results in terms of stopping the tumors from growing, and very few people develop any facial weakness. Some still progress to lose their hearing, but it's not nearly as rapidly as when you do the surgery. We were able to treat lesions in the brain called arterial venous malformations, which are these abnormal tangles of blood vessels that can rupture and bleed. Some of them, unfortunately, are very deep in the brain. They're hard to get to. The surgery can be somewhat risky. And with radiosurgery, we can treat them. You can define them like a tumor, and even though they're not really a tumor, the radiation can affect the blood vessels such that they involute and go away, and the risk of bleeding, the risk of seizures is diminished with that. There's a condition called trigeminal neuralgia, which is not a tumor at all, but it's a facial pain condition. And radiosurgery, when we aim it at the nerve, the fifth cranial nerve, the trigeminal nerve, for people with trigeminal neuralgia, frequently will eliminate what for some people can be a level of pain that can be life-threatening. In fact, before the medicines for trigeminal neuralgia came around, the most common way that people dealt with that was they committed suicide because the pain was so severe. So we were able to treat trigeminal neuralgia with radiosurgery. There are some centers, we're not doing this, but there are some conditions like obsessive convulsive disorder, overeating, depression, which previously have been treated with what's called functional neurosurgery. There are places that are doing radiosurgery for that, because basically what and in Parkinson's disease is something that you can treat with the Gamma Knife. We have not done that, but some centers are investigating that. There are certain parts of the deep brain and basal ganglia that you can create a small, essentially the radiation burns a hole in your brain, but you can interrupt a circuit that can have a positive impact for people with Parkinson's disease. So there's a lot of applications for radiosurgery in the brain. We've been fortunate now to have a 15-year experience doing this. We're partnered, like I said, with the University of Virginia. But we've done it, so much of it now. When we first started doing radiosurgery, we really relied upon the folks up in Charlottesville to steer us and to guide us and to give us assistance in planning these procedures. Now we pretty much, we still rely on them, but we've done this now for 15 years. We've pretty much got the same staff doing it. I've been doing it all these 15 years. There's a Dr. Ronald Kirsch and Dr. Joe Laser are the radiation oncologists. They've been here the whole time. And Dr. Kirsch had experience from University of Virginia. We have a couple of excellent medical physicists, Martin Richardson, Kelly Spencer, and they help us with the plans. And we've all been here for 15 years. So we've accumulated a fair bit of experience. Last year, we had a very aggressive young resident who wrote 5 different papers based on some of the things that we've done at the radiosurgery, which have been accepted for publication in some fairly significant medical journals. In fact, probably more publications out of Riverside have emanated from the radiosurgery than all of our other services combined over the past several years. Our hospital tends to attract in surgical medical interns who want to go into radiation oncology because we're known for this, because there are very few community hospitals the size of Riverside that have a radiosurgery like we have. There are other facilities in this community that have other devices that do radiosurgery. None of them is a Gamma Knife. We're the only one in the whole Tidewater area that has a Gamma Knife. And the Varian Edge that we have is a complement to that and does body radiosurgery. So we can treat tumors of the liver and lung with the Varian. We can treat tumors in the spinal column. There's no frame with that, but it's a similar technology. It's a little bit more complicated than the Gamma Knife, but it works in a similar fashion. All of those treatments are broken up into 3 to 5, sometimes 6 treatments, but still uses the same principles of delivering radiation to the 3-dimensional tumor, not to the 2-dimensional tumor that you would see on a chest X-ray. And that is, the beauty of that is that it targets the tumor only. So it's as effective as conventional radiation with a limit of significant cutback on some of the dreaded side effects of radiation. And so, like I said, we've had a long experience. We'll continue. Our icon is not even a year old. And we probably are treating 20% more patients than we previously were. They're not 20% more people with cancer. We're just taking patients that used to get conventional radiation and doing this gamma knife radiosurgery, and that seems to work better for patients. And like I said, I think the bottom line is cancer care just keeps getting better all the time. There may be an emphasis on COVID right now, and people that would otherwise be researching cancer care are probably worried more about COVID, but there still are plenty of people that are focused on cancer care, and that's just going to keep getting better as time goes on. And so we're fortunate to have this technology here. So I guess there's some questions.
Thank you. Yeah, we have a couple questions that have come in. I think we have time for two. The first one is this often used for palliative care as well, or is this really only for a full treatment?
Well, I guess it depends on how you define palliative. Certainly, if someone is symptomatic and has a lesion we can treat and is a candidate, we'll do it. So if someone has a tumor but has a terminal diagnosis, but that tumor is likely to in their life before the cancer spread elsewhere would, and or if the tumor is causing them symptoms, say for instance, it's causing them to have a seizure and you can't control it, but they're not a candidate for surgery and they're still having seizures, we would absolutely treat someone in a situation like this. And if you want to call it palliation, the issue always is that most cancer care, frankly, is palliative because cancer does tend to come back at some point in time in most people. So we look at the patient and decide, will this treatment cause a side effect that would cause harm? And if the answer is no, will this treatment give them a benefit that they would heretofore not derive from chemotherapy or other forms of treatment? And so if the answer is yes, it's going to help them not get weak, not have a seizure, not have headaches, not succumb to a neurologic demise, then we'll treat them.
Okay, and our last question today is if somebody is being treated and is not offered a referral to the radiosurgery center and wants to know if this is an option for them, how would they go about pursuing that, understanding if it's a choice?
So for the brain, they'd have to be seen. Usually the way the brain patients work come in is they have to be seen by myself or one of my partners, one of the neurosurgeons. We're sort of the gateway for gamma knife for brain conditions. The gateway for tumors sort of from the chin down is to see Dr. Kirsch or Dr. Laser in the office. And you can just call the radiosurgery center and ask for appointment, or call our office, ask for appointment, or ask most of these patients, I'm assuming if we're talking about metastatic cancer, have a medical oncologist, and just say to their medical oncologist, am I a candidate for gamma knife? And if the answer is yes, even if it's not, it's say, well, we'll call Dr. McAllister's office and get you an appointment and see if in fact you are. Some people aren't, but we're happy to evaluate everyone who's got the potential to benefit from it.
All right. Well, thank you very much. And thank you everybody for joining us today. We appreciate you tuning in, and everybody have a great afternoon.